It doesn't really matter if you start mid-back or low back first. I think Sarah had brought a good point with like her protocol. Well, she'll kind of start here because the glides will take her down to low back. But I'm starting here in the low back just because then it allows for this idea of going in this direction. But no, there's tweaks and adaptations you can already be making. But you do want to stick vaguely close-ish to something like this. And once you decide on even your initial tweaks, stick with it for a while, just so you can get that hardwired and memorized. Okay. All right. What side of the body? We discussed that in that it would be ideally the least affected side, but to try to mirror this, I'm going to come around to the left side. So when I come in and I get bolstered, you'll see even how the bolster, how it's situated. I want it to be right at that actual ankle joint. And the way I can kind of define that is by grabbing a hold of these big bony landmarks, the calcaneuses. When you think of your heel bones, calcaneus. I grab a hold of those, I make it feel like massage, but then I'm confirming the bolster is more or less in line with those. Great. Okay, here, knees, and come up. There's the sacrum, the thoracic spine, the cervical spine, the lumbar spine. All right. Now, I have to navigate, when first working in this region, I have to be able to identify where the iliac crest is. I need to identify where those ribs are, especially the floating ribs. That's going to be, and also relative to the ribs, is going to be a reason why I start you out with your directions of force going towards the pelvis, going inferior. Superior means up, inferior means down. Ribs tend to get stuck if we're having issues with them in a more superior, upward elevated state. For people like anybody with upper respiratory, asthma, breathing pattern dysfunction, it tends to be that. We're stuck in inhalation and we need help with exhalation. So, and even when we start talking about lymphatic stuff, the osteopaths were really big about making sure the thoracic cavity was pliable, more or less in this kind of downward squashing of the ribs into an exhalated state, because it creates a bellows that helps move fluid. It's literally a suction, like between the ribs and your diaphragm and your belly, like an inhale to an exhale. As that closes, it's actually pulling stuff toward it. So good breathing is associated with fluid movement dynamics. But breathing is also just important in general, because oxygen, yeah. So the direction of force we put on the ribs, if we make sure that's predominantly downward, that's good. It also leads you to not inadvertently hit this, okay? Doesn't mean that I and you will not have reached a point where you're comfortable enough with recognizing where those are. So you go, no, I can avoid those and come over top. But starting out, it's really common to just inadvertently let your elbow drop too much and hit those, and that's a bad time. So in order to eliminate that, if you just keep your direction of force, sorry, let me move this up a little bit. Then you don't have to worry, because even if you go over those floating ribs in that direction, it won't be ouchy. So that's the argument. From here, I need to be able to find this, and then something you want to avoid is the tendency to, when you find these bony ridges and landmarks, to push more into them, okay? Because your force is going to take you where you're looking. That's the nature of the body mechanics. That I can make myself do a compression that's just straight down, but predominantly compressions are going to have a touch of a direction to them, even if they don't glide, right? So I need to sometimes make contact and then adjust myself and try to make my pressure come more straight down rather than in a particular direction. That's where you'll create an ouchie. You'll never create an injury here, but it won't feel good if I'm doing this. It'll feel good if I'm here, I glide to where I meet that edge, stop, and then maybe go along that edge. So the directions tend to be like this. I go down on an angle towards the iliac crest, then pivot and go across, letting that line guide me. Okay, then moving up here, we can cover this lower half of the thoracic spine, not worrying too much about the floating ribs. And I come up here, and moving this, now this scapula has been bolted to the ribs, so it's not going to move like it normally would. But the scapula can move all over the place. It can slip and slide in essentially every direction on the ribs. Bringing it this way will bring it up, creating more space here for us. Bringing it down here in particular, if we bring it here, it will come up and create a smaller window for us here. If we want the sweet spot, and if somebody can't lay like this, then we adapt. But if we want the sweet spot for being able to work on the structures between the scapula and the spine, and also up here, just a little bit superior to it, coming into the cervical area, the arm off to the side is going to be where we have the easiest access. Now, you can use either arm, but this one I find a little bit more convenient just because I can hold the arm in place and then I can incorporate some joint movement. Right? And that's why I orient my arm like this, because I can go right in between and then I don't have to worry. If I orient my arm like this, I'm bumping into the scapula this way. If I orient my arm like this, I'm going to end up on top of those spinous processes. So, here. And then trying to not let yourself get too crooked like this. Let yourself square up so that ultimately your arm's like this, not like that. Should be on a little bit of on an angle inward, not perfectly horizontal, not perfectly vertical, somewhere in between. Even a tiny little bit internally rotated like this is nicer on your shoulder joint, I promise. All right. That pretty much sets you up for navigating around this first part of the scapula. Cool. Now we're to the upper arm. And in your books, aside from the skeleton pictures, there's those charts there on the table if anybody wants to look at those. But also, in chapter 9, we have page 307 and 308. So if you were to kind of go back and forth from right now, we're looking at like page 201 and 307. I would give you two pictures that skeleton to muscles. Am I giving you the right page numbers? Okay, good. Making sure I'm not in the wrong edition of the book. All right. We talked last time about how on the medial side of the arm, we wanted to avoid the main nerve and artery here. So the way you can get to that inadvertently is if you were to work coming at it in this direction, either here or here. Does it mean that in time you won't be able to do that and do it safely? But then you might as well go here. I tend to stabilize the elbow and work on an angle, working perpendicular across the bone. Could use a forearm if I needed to do more work here. Ideally in any body area, and we'll just come more around to this, but ideally we move the tissue in at least 2, if not 3 directions. That's kind of the formula for just making sure you do your due diligence for each region. But this tends to be my most efficient. And then going, if I'm going to go more in a second direction, it would be like this. And I can even grab a hold of the elbow like this and stabilize the arm and work like that. Okay. Humerus, the muscles there would be the triceps, covered. Now we're to that whole element of the forearm that can be a little bit initially confusing. The only way I could make this anatomic position would be to turn that all the way over, which will be comfortable for some, but not necessarily for others. People with shoulder issues, to turn their arm, even pronating, it's not just to do this completely, ends up not just happening at the forearm, particularly when we're pinned against a table, hard surface like this. The shoulder will have to externally rotate too. So some people will be able to do this comfortably. And when they can, I do that because it ends up being good for that shoulder joint. If I were to work on this side of the forearm like this, see how it's inadvertently creating some nice little shoulder motions? But there's a few factors here that make it kind of messy. Ideally, not everybody can do this. And if the edge of the table is kind of sharp, then I can make it uncomfortable. So I've used it a lot, but it's not a common thing that massage therapists do. But that would be the way to work on all the posterior elements of the arm. If we have a person laying like this, which is going to be the most common, then you're working on the anterior, you're working on the posterior upper arm and the anterior lower arm. So here, this will be the way you are pretty much going to typically work on it. So practice this and maybe incorporate some of this. But looking at it this way, this is one place where I change up my body mechanics just out of pure efficiency. Although there's a bit more of a hill this way in picking which arm to use. By and large, it's going to be this. My pelvis and my hips will kind of be open to the table, and it'll be the arm that's actually furthest away from the table that's able to come over. And although it's counterintuitive, the table will stop me from being able to use this one effectively. And this one, I'll have to twist. So it's this one where I'm not going to be twisting, and I can actually lean forward more and get to the middle of the table most effectively. However, when something's right at the edge of the table, then that's less of a concern. But if I'm going to pick this one, that's going to be a silly decision because of where my hand would go, right? I could pick this one, and that's okay, but going in that direction, I have to try to control that arm, which lots of people do. They'll kind of pin the hand and work like this, and that works fine. I'm lazier than that, so I pick this way. So I don't have to worry about stabilizing the arm. I can make contact here starting at the elbow and work my way down towards the wrist. Perfect place to start your kneading, this idea of a push plus a pull. You're going to see with that is a really good example of working on the tissue in two directions. If I take it in a direction that runs parallel to the skeleton and then a direction that runs perpendicular to the skeleton, I'm always getting two directions. And I tend to think a lot about that. Am I taking the muscles in the direction of the bones or in the sideways perpendicular direction to the bones? Then here, this is where I think about the carpal bones and the metacarpals using the soft fist. We have to watch out for the thumb a little bit. So instead of just doing this, I tend to bring my hand over and just hug that thumb joint a little bit. But that's all that's happening here. And then I'm being strategic because I know the anatomy. I can visualize all those little bones and I can think, okay, if I'm closer to the wrist, then I'm going to affect the carpal bones more. If I come closer to the digits, closer to the actual fingers, I'm going to be more on the metacarpals. And once I'm on the metacarpals, instead of working like this, I'll turn. I'm going to keep my hand like this so you can see. I put my knuckles in line with each of those long bones. And then I know if I do that, every time I work my way down and I just count my way down the fingers, I know that I'm creating these little bends in between those long bones so that the muscles in between are kept happy. That's the method to the madness. Done. If I was looking for a shortcut, you could turn this over and do more, but there's no point in doing that because of how we have this labeled, right? So we're going to stick with how this is labeled and not do any kind of cheating. All right, person gets to lay back the way they would. All right, quick and real time, contact. And then forearm, finding the iliac crest, and then going across towards the spine. Forearm going down towards the iliac crest, following that line towards the spine. Taking a step backward, getting up onto the ribs and the thoracic spine, going downward, and then across. Downward, inferior, and across, medially. Then I will reposition the arm, identify the scapula, place forearm closer to the cervical vertebrae, work my way down. In this one, initially, you're pretty much gonna go in just one direction. We'll work on some ideas of working in, you can always use your palm and just go starting at the scapula towards the spine. That feels really good, but worry mostly about using your forearm here to start. And then we'll come into how you can do more. Okay, hands are already holding the humerus. I'm already making contact with the triceps. So I bring this hand down. We start working our way down. I'm stabilizing at the elbow. Work my way down. If I need to, I use a forearm to go up. Replace the arm. Find the elbow. I tend to actually cradle the elbow. This is a good thing to try to do. It won't work all the time, but to stabilize the joint that's a step further out from where you're working. So by holding the arm here, I'm stabilizing the shoulder while I work. And then while I'm working on the upper arm, I stabilize at the elbow. Working on the forearm, I stabilize at the elbow again. And then, no, that didn't work perfectly in my analogy. But anyway, if you can, stabilize an adjacent joint because it makes it safer and makes it easier for you. All right. Okay, so elbow, forearm on forearm, then knees, soft fist, a few directions, following that all the way down those long bones, and then we're good, we're done. Now, we're to this part, which would be the area that probably, you know, the scapulas, although they will annoy you because you're trying to navigate your way around these lines, will be kind of frustrating. Like if you're trying to work, that's why I also tell you initially not to go working superiorly because you'll tend to hit that inferior angle here, and that can be an ouchie time. Can't tell you how many times I've had therapists when I was traveling just bump into that and just washboard their way over top of it. So what they're trying to do is this, okay? I think that's just so silly because one, it's harder on my shoulders. Why not just step around and do it this way? I'm not gonna potentially hit their scapula and hurt them, and I'm gonna maybe help their ribs out. So that way. Down here, this is where we have a couple bony landmarks to identify somehow. Somehow, I'm gonna blame the skeleton or something. I don't know what I got on me. But, you ever see me or other therapists doing this? I'm just following the arc of the low back and bumping into the top of the iliac crest. So I can identify where those are. And then, visually, I'm kind of mapping that out, and you can make a pretty safe approximation, right? Now I can do that, or I can put my palm like this right on the sacrum. Right? This isn't invasive. We're not like down here or anything. But right here, I can identify where the sacrum is, and either side of that, feel where the pelvis is, and then I know we have this whole area to work. And then the next thing to identify is that greater trochanter. All right. That's why incorporating the joint movement in the session, in the actual massage application, this is the first place where you really want to get good at that. It's because it allows you to find all of that really quickly. Hand here, either like this, doesn't really matter. Find where that is. Then I need to just follow that whole crest, not be on it. I gotta be in this cavity, right? Gotta make sure that my elbow isn't inadvertently up on that edge. My elbow has to be, we have lots of room here, okay? So, here, plus movement. Change your arm's orientation. Now I'm here. So my first forearm was on an angle like this. And then the next one's gonna run this way. And it's gonna naturally cause me to apply pressure more on the lateral side of the body. So here to there. That's it. Here, move, move, move. Change my orientation, move, move, move. Then we gotta be more aware of that greater trochanter. And if you keep that moving, it'll guide you. Like this right here, when I have my arm like this, if I'm moving this, I can feel that. And then I know exactly where to put my forearm for the next set of muscles. Up here are the glutes, gluteus maximus, and then you have gluteus medius and minimus. Probably not getting minimus too much, but you're at least getting gluteus medius. Right here are 6 muscles that attach from here to there. And they're called the deep lateral hip rotators because they do what? They laterally rotate the hip. There's 2 terms for rotation, and I'm sorry about that. It's lateral or external rotation. They mean the same thing. So lateral is external. External obviously makes sense, right? But lateral, the lateral side of the body. Medial is the inside of the body, so medial rotation or internal rotation. So lateral rotations, medial rotations. External rotations, internal rotations. They get used interchangeably. Why that's important, and I don't really care if you mess it up, I also want you to be doing the joint movement, is that you'll see the foot going medially, but that's lateral external rotation. Then you'll see the foot going outwardly, that's internal or medial rotation. There. I'm using this to cause this. Thus, this won't do anything for that. So you can hold this wherever you want, either to a comfortable range for the person, but most especially for yourself. So I don't hold it like this, right? I bend this to where it's comfortable for me. Now, with this one, what you're gonna start out with is if you get your arm oriented, you just have to practice this. You gotta practice palpating this and getting your forearm set. Once you find that little nook, it'll feel natural and normal. And then if I roll that hip this way, I'm gonna feel that bone come right up into my forearm. If I move it this way into internal rotation, medial rotation, I'll open that space up and create a stretch on those muscles while I'm pushing on them. So it's a double win for causing benefit here.
So what happens if somebody has like sciatic problems?
Yep.
Where would be like the, okay.
That's where so sciatica impingement of the sciatic nerve, which is a nerve that goes straight down the back of your leg from your sacrum. If it's gonna be pinched via soft tissue, it tends to get pinched here. If there's not something weird happening here, like with the SI joint or the structures of the nerves that they're branching out from the sacrum, it tends to be here, in these deep lateral hip rotators. 6 muscles, the most famous one is piriformis, and with sciatica, many people get diagnosed with piriformis syndrome. Real piriformis syndrome would be where the nerve is actually developed going through the belly of that piriformis muscle, and that does create serious issues. Like I'm muscle fibers that can change shape, and I have a nerve that's actually growing inside of there. Now that's going to get clamped on every time that muscle contracts, right? Now, that's only a smaller percentage of the population that has that. But it can get, since there's all these layers of muscle sitting on top, that nerve, does it show? Yeah, there we go. That yellow thing. So it has to come out underneath, through piriformis, and on top of a few of the other deep lateral hip rotators to go down the back of your leg. So working here, you're gonna hear people talk a lot about piriformis, but the other rotators are important too. But that's why we gotta work there, because sciatica is one of the most common issues relative to low back and nerve pain. So how am I gonna affect those? I have to find this greater trochanter and put a forearm there and move the hip back and forth. That's gonna be my key to success. And then with more knowledge, you'll get more awareness of that. But if the assumption is that they're too short and tight this way, and that's pinching the nerve, then I'm gonna compress that tissue to reduce its tone, and then I'm gonna lengthen it to make it longer. And that's my magic solution right there. And so this just tends to look like this. Glutes, external rotation. Deep lateral hip rotators, internal rotation. And I'm done. Here, remember that the hamstrings do this. They attach onto the ischium. There's not a whole lot over here. You have the glutes, you have the IT band, you have padding in soft tissue, right? But there's not a particular muscle to worry about right there. Okay, so forcing a glide like this is gonna be an ouchie time. If you haven't accidentally done it to somebody, I mean, try not to, but you know, if you have a good lab rat, maybe it's worth experimenting. But right here, we only really need to worry about if we're using sideline, like I'm telling everybody to do, dang it. Well, if we're using sideline, like I tell everybody to do, there we go. We only have to worry about certain sections of the body, and initially it's gonna be kind of this chunk, call it more than half, closest to the knee, all right? If somebody can only lay in prone, then we got to do a lot of like adjusting of their body so that we can get to this stuff more effectively. Or I could like work cross body. But if I know the muscles go from here to there, right, that's the hamstrings, then I'm going to save my time and energy and not try to just fight through it here in prone, because the only way to do that here, and I've done it, but I have to do this kind of stuff. So save your shoulder, save your energy. Worry down here, worry closer to the knee. All right, if I was incorporating joint movement, it would look like this. I can just leave the leg like that and work like this. So with the bone, across the bone. Good. Using this form also keeps my hands out of the way. Now we're gonna swap it just to go up the calves. Same principle on the calves. The medial calves are really important, but we'll get those better in sideline. So here, could go with the bone, across the bone, with the bone, across the bone. Could always do some knees and stuff too, but I'm trying to focus on forearms. With the feet, if you have access to sideline, save your time and energy. The one thing that I do use here is just kind of a way that feels good, but also does something effective, is I grab a hold of that calcaneus, give it a good squeeze. You have a fat pad on there, and when people talk about plantar fasciitis, that plantar fascia attaches onto this edge of calcaneus and then comes down to the rest of the foot. Creating any kind of separation here will feel good. Smashing down on it does not feel good, and it doesn't do anything. So heel squeezes, or just a tactic I've used, is one that feels good, but is also potentially effective for foot-related issues. Also, if I have a hold of this, I have a hold of just one tarsal bone. So if I stabilize this, now it attaches to that bone, so that's talus and calcaneus. Only talus actually touches the lower leg bones, it becomes an ankle joint, and then it sits on top of this one. But I know they kind of go together. So if I hold this one down and then move the rest of the foot, I'm doing all kinds of good stuff. Depending on where I put this hand and where I'm moving it, I could be thinking more about the tarsal bones, or I could move my way down and be thinking about the metatarsals. But I'm just gonna hold that calcaneus and then do that knead action. This is a push and a pull. And if I wanted to, I would do it in the other direction. Hold this one, push it that way, pull these that way. Get a lot of potentially good stuff done. It'll feel nice, and it got me to the other side of the table. And I'm here to do it all over again. So, in speedy time, finding the iliac crest. I think I'm actually a bit more prone to putting my palm on the sacrum these days. I tend to come down, find the sacrum, and then I'm right here. Gluteus maximus, gluteus medius, deep lateral hip rotators, and come down, thinking the hamstrings. Then, instead of saying the calf muscles, we can start using at least one muscle term. The big one that you see, the big heart-shaped thing, where a runner has a, super defined gastrocnemius. It's the muscle here that crosses, actually the muscle that crosses behind the knee, and then also comes all the way down and becomes the Achilles tendon. So gastrocnemius is a really important muscle. With the bone, across the bone. Go with the bone, across the bone. Come around, heel squeeze, push and pull. Heel squeeze, push and pull. And then we're done. And then it's rebolster and rock and roll. Okay. Go to sideline. And I'm going to do only like one rotation on sideline here. I'm going to show looking at it this way. Now I'll do both. I'll just speed up the other one. Why do you need this? Because if a person is asleep and unstable, you will. Okay. Now, with a pillow, and will they stay? And then I'm going to give a hugging pillow to hold said thing up. And a hugging pillow is a good thing to really consider incorporating. Okay, 2 pillows is a very helpful thing. All right, there we go. Now, we're starting here. Like, there's some changes that I had to make just because of the numbers and how they played out, but here, if you want to, think about like the one really being more incorporating the head and the neck, kind of. So, here's the temples, the whole skull and scalp area, but I'm not going to worry too much about the individual muscles. Just thinking about this crazy cranium to start with, we have a lot of space here at the base of the skull. The muscles are here. You'll find these pretty easily. These aren't as easy to find, but start feeling for these bony prominences at the base of the skull. They will guide you moving forward. There's one right here, right behind the ear, called the mastoid process. You can follow that all the way back to like the central one. And there's kind of a ridge that follows the base of the skull, and you'll feel like a central bump right at the very back of the skull. That guides you with, ideally we want this always in line with the spine. But using those bony landmarks, that's where I can approximate where particular muscles are. Most of the muscles that are here, what we kind of think of as the shoulder, but here's the shoulder, this is the scapula. So most of the muscles that are attached to the scapula and the shoulder girdle region come all the way up across the cervical area and attach onto the base of the skull. So upper trapezius, levator scapula, the muscles that people think of where they want that extra work right here done, those go from there all the way up to here. All right. So I'm already standing here. I've worked on the head. I can do some kind of just nice stuff for the neck here. Sprinkle in the occasional just nice thing. And it should feel more or less you're just like moving the skin and the superficial fascia just under the skin. You're warming the area up. And then this is an important point for where we want to work. Right there is the acromion, this crazy big sail that turns into the spine of the scapula. This is the medial border and that's the lateral border. This is called the spine of the scapula. But this crazy plateau right here is called the acromion. And it's what attaches onto the clavicle. I don't need to push on that. This isn't going to be a good time. This is not a good time. So right there is the superior angle of the scapula. So there isn't a ton of space here that we need to worry about. That's why we follow contact with the neck, cervical spine, let that guide us toward that first rib. We're only going to be really working on the first two ribs in terms of the thoracic region of the spine and the ribs here. So here to here, maybe based on where the person's sitting, and I should have had this person scoop further back, shouldn't I? That allows me to not get trapped here. I can come around to the corner of the table and work like this. And that's going to feel better. I can do a pressure application that's kind of more directly right down into the ribs, and that'll be more intense. If we want something that tends to feel better, it's going to be grazing across that. We don't want to go this way. We want to avoid the neck. So we go this way. Here, across. Across. But I contact the cervical area, bump into where we're hitting these first two ribs, and then go across. And then that same application will be done all the way up the neck, depending on how big of a neck we have to work with. Might be a small neck, or a big neck, a long neck, anywhere in between. Now that's one really good direction. I could do most of my neck work like this. But if we're working our way towards dealing with like potential tension headache stuff, then I need to try to get maybe a little bit deeper here at the base, because there's a lot of extra stuff deep there. And that's going to be where we find the base of the skull, but then I don't push into it. I stop and then try to let myself drop straight down so that I'm pushing between it and the cervical spine, right? So that's the common mistake people make. They come up and then they're like this. And that's an ouchie. As opposed to finding that and then adjusting my angle a little bit and sinking more straight down. Done. Then we're to the lateral side of the body, and this is one that just can be a journey for you to navigate, and it is what it is. Because we're dealing with trying to get, let me turn this over, we're trying to get our pressure more between the scapula and the ribs, or what will feel more like you're right on the ribs. But I want to move that scapula out of the way, and I want my elbow to maybe be just over that lip, and then we'll be more or less right on the ribs. The benefits there will be, one, we're doing a nice compression on the rib cage, and two, the scapulas tend to get stuck protracted forward, slid forward this way. They need to be pulled back. The way I can do that is by setting my arm and then trying to, I can't do that in the skeleton, but kind of trying to nudge it this way. So this is what my arm is really doing and what my intention is. I'm trying to get my elbow over that lateral border of the scapula onto the ribs and the muscles that are sitting on top of the ribs, whether it be latissimus dorsi and then specifically serratus anterior. But this is my goal, and then there's going to be, as we do this, I can't cause this rotation with this thing. I have these right here. And while I'm applying pressure here, I want to get this moving back and forth. Ideally a bit more this way. People get stuck this way. And I'd like to kind of nudge that scapula down. That's into depression, a good side of depression. Elevation, depression. People are usually elevated and protracted. I would like to make them depressed and retracted. So we do that pretty naturally if we can just get our form in the right place. By doing this and setting the arm down and applying pressure that kind of tracks towards their back and then pushes the ribs down, and then I hold their acromion. I find their acromion with this palm, and I know my scapula is pinning the scapula on this side, my hand is pinning the scapula on this side, and then I'm just doing this. And making the scapula move with my forearm and my hand concurrently.
And you said that's not actually attached, like, to the ribs or anything except for at the,
By bony connections. It has some connective tissue elements that does,
but not
Okay.
any,
but not a structural bone-to-bone attachment. Yep, it just slides. So it's able to do all that because there's no bony attachment, but then the clavicle also is doing actions. If you hold on to your clavicles and start shrugging your shoulder around, you'll feel that clavicle moving all over the place too,
that
right?
is attached here.
Yes.
Or that's the only place it's actually
Yeah,
bonially
yeah.
attached.
So it has to pivot here. Your clavicle is pivoting like this to allow for those motions as the scapula is doing its ability to go up and down, forward and backward, and then also rotate. When I do this, so crazy thing, but people tend to get stuck this way. So I know if they're like this, I can take them that way. It's always going to be a win.
So is there like a pattern of motion that you like to do, like a circle, clockwise,
Yep.
counterclockwise, like?
I'm always nudging it down towards the pelvis and then towards their spine. So it kind of has a toward the pelvis, toward the spine, and then rotate back up toward the pelvis, toward the spine. And I don't glide much here, even when I'm on skin. That's why I'll say, like when you're up here, don't try to turn this into a glide. Make this more of a compression. If the glide happens, let it happen naturally on its own, but don't force it. Make this more of a compression plus some movement. You don't need to come all the way down here. All right, done. Now, this part, why I tell you not to use the arm going towards the ribs, use the arm towards the pelvis. That way you don't hit those floating ribs. You're gonna feel like this is a bigger window than most people. Like this will feel like a smaller space. But if we go in this direction, these will tend to squash out of the way and everything will be fine. The only time you really have to be super cautious here is if there's a really bad osteoporosis. All right, so I find the top of the iliac crest, and then I just go straight down. But I'm not going to mash into it again, but I find that and then adjust, try to go straight down. Or I'll take a step back and let that guide me like a line across. And I can even start angling my arm. If I have a person rotate a bit more for me, this is where I can get some really good work here if I can't find a way to do it in prone. See how I could get my elbow placed right there at the SI joint? I can hold on to their traps like a handle. That feels good. Right there. So finding the iliac crest, straight down, and then moving my way back and either being more up on the lumbar spine or down closer to the sacrum. That'll get us to everything. Now, if we were all in sideline, we certainly could work here more for the hips, but I had to make decisions, so I prompted in the all sideline routine. We'll look at working here more, but with bad hip issues, you would want to figure out a way to work in this area more, because you can get on gluteus medius and minimus, and obviously that's going to be really important for the hip joint. You can get it okay in prone and supine, but that's another area that we are not fully covering, but it's not too hard. Greater trochanter, here. The issue tends to be if the table is too high for you, then you need that step stool so that you're not trying to do this. You have to be higher up. You can come more straight down and be between the iliac crest and the greater trochanter, and you're right where you should be. You can work your way all the way around the hip joint. You just can't incorporate the joint movement in the same way. So, all right. That's how you could still work on all that in sideline, and it's not really that big of a deal. You're just limited a little bit by being able to incorporate the joint movement. All right. Now here, for the rest of the hamstrings, knowing that they attach there, this is where I can get the rest of it, including the inner thigh muscles, which is another group called the adductors. But if I have my elbow dropped down more like this, I'm going to be on more on the posterior side. If I flatten it out, I'll be more on the medial side. So then this whole stretch, I'll just turn into elbow more bent, elbow more flat, and then it's either more with the bone or it's across the bone. So here, and here, here, and here, here, and here. Hands out of the way, only an elbow coming close to the pelvis. That allows me to get up on those hamstring attachments without it being particularly invasive. Worst case scenario, could go right over top of the sheet, right there if I had to. Okay, then flip it on the rest of the calves. With the bone, across the bone, with the bone, across the bone. And then maybe some more work here, thinking the medial side of the Achilles. There's a bunch of muscles that come through this tunnel down to the bottom of your foot. So however it's comfortable for you, important area to address as well. Then we're to the foot. That one's not too hard. I hug it with my fingers, so I hug it with my hands. Can't go wrong. Come around, lateral side of the leg. This is one that I personally actually don't do in my regular routine because I get it in prone and supine, but we can find ways to work here. The IT band itself doesn't necessarily need pressure directly down on top of it. It's best suited to kind of pull it away from the quads, the anterior compartment, and pull it away from the hamstrings, the posterior compartment. So if people want that sensation, then sure, you're not gonna hurt anything, but it's gonna be just kind of intense for the sake of an intense sensation. It's more effective to get that target connective tissue unstuck. So I go across, maybe kind of on an angle along that line to unstick it. And same thing, across and along that line. Then here is where I can get all the muscles of the anterior and lateral leg. You have a chunk of muscles that sit right next to the tibia, and you have a chunk of muscles right on the fibula. So, elbow more bent, I'm more anterior. Elbow more extended, I'm more lateral. So, tibialis anterior and extension digitorum longus, and then fibularis longus. Those are the muscles I'm thinking of. But anterior compartment, lateral compartment. Anterior compartment, lateral compartment, hand underneath foot, and then this is where, if I use the claw of my hand, I can get more strategic. And this is how I tend to think about the individual tarsal bones, is I will curl. There's a line here. I can't show it as well here on this model, but the lateral side of your foot that touches the 5th and 4th metatarsals is more structural. The rest of it, what we think of as the arch, has a lot more mobility. I think about the line between the two as an important place. So I, at the very least, curl, approximating that I'm in line with the middle toe, the 3rd phalange or metatarsal, and then just glide across. And then I can work my way all the way down and do the same thing for all the metatarsals, too. And I can get real precise there, right? Without using my thumbs. As far as the individual toes are concerned, I do grab the big toe, like here, and I grab the little toes here. I do it all as one. I will put my fingers right in line with their toes, grab them all together, give them a squeeze, and move them back and forth. And then the big toe individually. I don't have the biggest hands, but like Sandy has smaller hands, and she'll thread her fingers in between. It's too ticklish for me. So I don't tend to do that one. But there's an argument for being able to pull that off, if you can. It just has a particular sensation to it, and if somebody's ticklish, that's really gonna be ticklish, okay? So I tend to, the toes all together as one. And then the little toes all together as one, and then the big toe by itself. So, we saw that. I think that covers sideline, okay, right? So we're just gonna go right to supine. All right. Time. Okay. if you're ever interested, these skeleton models have been getting less expensive over time. So you can get this one for like 120 bucks. It used to be a lot more than that. Even like the Halloween skeletons, a lot of them aren't like perfect anatomically, but they can be a useful thing. Just their joints won't be able to move in all planes of motion is the only thing. All right, and then bolster. Right at the knee line, always bolster, unless it specifically is uncomfortable for the client, but just always bolster. All right. Here we go. We don't have to worry about any of this following the protocol as we are. If I had to, if I was limited in working in sideline or couldn't work in sideline at all, then there's ways of kind of how you would orient your hand. You got to turn them over a bit and hold the foot. Maybe you could use a forearm here. It tends to make the most sense for me, if I had to just sit down. And then you can come it out of that. It's not too bad, as long as I don't go over with the broken stool. But in our routine, all we have to worry about is the anterior leg and then the anterior part of the hip. So this makes a lot of sense as long as you move their body. If you let them lay like this, there's a lot of people who will turn out like that. It's a bit extreme, but there are plenty of people where they actually do look like that with their feet are just. So that's something where it was important to adjust those deep lateral hip rotators, because if those are too short and tight, they could be causing that. But anyway, move their hip. You can, any part around the knee, could be above the knee, below the knee, just turn that leg over. That'll give you access to the IT band and the lateral part of the anterior chunk of muscles here, which we think of this as the quadriceps, and you have one more on top of it. You have the quadriceps group that we hear about, then there's sartorius that sits on top of those. So I turn the leg into internal rotation, glide across like that, maybe go a little bit in line, then turn it a bit toward me where I'll look at the toes. Now I've made the toes turn that way on a 45-degree angle, then ideally up towards the ceiling, then same series of applications. And then turn the other way, and the same series of applications. And then we could do more, of course, but this is a good place to start. And you just don't want, because this is downhill, you don't want to be trying to do this. You gotta be going on these angles, because then here you'll always have a hill. So this needs to be 3 applications, not turning it into 1, okay? If you wanted to just have a hill to do that, then you gotta go this way. But I tend to, only if somebody's really sensitive, like if people have a sensitive quads and this is painful to work in this direction, then using a palm and going that way will tend to be way less intense. So if you have to defer to something for just their sensitivity's sake, then I go to that. All right. Hip flexors. This would be easier to see when I go over to that side. But now we'll eventually get to where like we're kind of palpating specifically. This is a portion of the iliac crest called the anterior superior iliac spine. It's not superior to it, it's just anterior to it, whatever. It's that bony hook you can feel right there. There's that, as the greater trochanter. I want to be anterior to it, right there. Chunk of muscles, really important, are chronically tight, right there. And then figuring out how to get my forearm set. Usually I can just kind of turn it into what feels like a massage, and I'll go over the sheet to start. If I can, sure, but it tends to be uncomfortable. So I tend to work on the skin here, and I'll re-drape, and I go over the sheet here. Unless there's something really specific going on, like scar tissue from surgery or replacement, something like that, okay? Well, all I have to do here is kind of find, oh, there it is. There's that iliac crest. If I roll the hip around like this, I can feel where that greater trochanter is. And I want to be right there in between. And then I'm just going to incorporate joint movement to create friction under my application. And if there's something more going on, then this is a good place to start with some muscle energy techniques, where we just tell a client, just roll your hip inward and outward like this while we hold this pinned. The points of application are going to be more straight down into the table. The reasoning being those muscles attach right onto that, okay? The first couple of muscles. Attach right down onto that, and then either go straight down to your patella or go all the way over into the medial side of the leg and attach onto your tibia down here. So that's rectus femoris, the big top quadricep muscle, the first one, and then there's sartorius, which is the longest muscle in the human body for you at trivia. Here, and then I step a little further away, bend my elbow more, so I'm more lateral, and then I'll get some other muscles, specifically one called tensor fascia lata, because it tenses a lot of fascia, which is the IT band. A tiny tensor fascia lata muscle. It's right there, and it's the one that's predominantly controlling the tension on the IT band. If somebody has issues here, if you don't work here, you're not going to really affect it. So here, then here. It's really all that you need to do. There's also gluteus minimus there, but just those two places cover some really important muscles that don't get addressed. So, yeah, that's all it is. Not a big deal. All right. Then, up here, we did pretty good last week talking about where to get placement on the chest. We need to avoid that clavicle. So you have to, get a hold of the arm, contact right up here with the shoulder, finding the acromion, finding that shoulder joint, find the clavicle. Confirm where that is, just so you can start getting a better sense of that and building out your palpation awareness, right? Now, I gotta be here. Between, there's this, you won't palpate this, but there's this crazy hook right here called the coracoid process, and a bunch of muscles attach onto that. So I gotta be here in between that and the ribs. That's where I'm gonna, pec minor, coracobrachialis, really important. To get my hand placed correctly, and it'll look a little bit easier, you'll see it a little better on the other side. If I just make contact with the table with my hand and fingers, my forearm will naturally be oriented in a way where I can't come up on that clavicle. And then what you just have to watch out for is you don't come down right on the shoulder joint. You want to feel like you're pushing more into their chest, into their ribs. And then movement. And right here, then it's easy. It's working on the biceps in this direction instead of this one, initially just to avoid the nerves and arteries. Right here, I can go that way. Then here, I tend to use actually this, I use my palm here on this side of the forearm because there's not as much muscle over here. So I tend to work here with the bone, across the bone, and then work to that whole finger squeeze thing. Now, I'm going to swoop around, and what all that looks like in real time. Be here, undrape, contact, roll inward, turn a little bit outward, toes to the ceiling, again and again and again, turn outward, again and again and again, reset, find one way or the other, however you have to. You have to palpate along the lateral side of the leg to find that greater trochanter, and then use that. You know, we're in school. You have to find a way to find this stuff and identify it. If you ever see chiropractors, there are people doing this kind of stuff. That's what they're palpating, is that anterior superior iliac spine. So I find that, pressure straight down, and then I might rotate that hip around or ask the client to do it. Step a little further back, bend my elbow more so I'm more lateral, and same thing. Come up, find their arm, contact the table, comes right in line, not here, into the ribs. Movement, step back, contact, down, with the bone, across the bone, hand squeezes, and fingers. That pattern, I tend to do the 5th and the 1st together, the 4th and the 2nd together, and then the 3rd and the 1st. All right. Now, how do I have this labeled? Oh, I have it labeled as the abdomen to start. And it fell into my routine because I tend to do that at the end. So, you have to forgive me on that one. We'll come back around to it at the end. That would allow you to just finish things up with only it being kind of the nice stuff at the neck. If you've worked on the neck and sideline, then it allows you to be in a position here where we could just make this nothing but palliative, feel-good stuff. The one thing about working on the neck to start is don't do too much where it's just your hands on both sides working together. A little bit of that feels nice and is good, but if you're gonna do more work here, go to one side, either sitting or down on a knee. If I take a soft fist, plant it on the table, can't miss. If I do this, I can miss. So, right there. I could use that soft fist, my knuckles to work on the neck, all the way to the upper trap spot. And I could reach underneath, hook onto the other side of the neck and work on that side of the neck like this, with this pulling action. And that would look like this over here. Pull in the head, soft fist, you can't see any of that. But then this hand comes under, curling over, and I'm here. And I can either make that more broad or more targeted. Cool. And then forehead squish, temple squish, swooping. The part that I have labeled as the first things to do, and I'm swapping, we're at the end. I'm sure I had good reasoning for that to start. Let's see if I can get this to balance. No. So, important that the knees be bent when you're working here. Creates slack, flattens out the low back, allows you to move them so you can get the stuff, okay? But I don't think it matters, because you could have a person turn supine, keep their knees up before you put the bolster in, and do what I'm about to show, and then end right there at the head. I tend to like to end with something a bit more active, just one to kind of wake them up, but also if we're ever dealing with somebody that's like blood pressure, regulating medication, stuff like that, getting them more woken up and doing something active keeps them from getting dizzy when they first sit up, or limits it at least. So, assume that they're sitting like this as I'm talking about the rest of this. We're able to talk about initially working on the abdomen, but we're going to be also affecting their low back. These muscles, except for the six-pack muscle, that's rectus abdominis. Rectus means the middle of, so rectus, middle of the abdomen, rectus femoris, middle of the femur, not too bad. But the other 3 abdominal muscles go all the way around. So this goal is gonna be to use one hand or 2 to get as far over to the low back, the lumbar spine as we can, and to pull, creating this nice torsion this way. And that's gonna distort the entire abdominal cavity. If I do that on both sides, then hey, ideally we've had everything kind of pulled away from the spine and squished and grouped here in the abdomen.
Can you say you do that with the knee though?
Yes. So I'll show how I get away with it using one hand for their legs. And that will kind of, but you should, starting out, think about your body mechanics. So have them holding their legs here, maybe, and ask them to do these motions. But you're gonna have them do this, and then bring their knees toward you. That'll create space here for you to get your hands underneath of them to be able to pull on that little back. You also may need the step stool and or the table lowered for this. Then this hand, or both hands, come all the way over, and I'm just gonna drop and pull. The mechanic of that, when you do a pull, is keeping that back straight, letting your butt do the work. Okay? Here, rotate toward me, hand or both hands, underneath. And then they rotate the other way. And that'll create the twist. We will teach you initially how to drape that, where a person, you're gonna put a towel on top of the chest. You should already have that if you're using my technique, putting the towel on the sideline. They'll hold the towel and you can pull the sheet down, creating a little window here. I also show you an option where you just pull the top sheet up a little bit so you can create a little window, get your hand underneath and do it that way. It's a little bit less draping stuff to be finicky with. Okay, here, and then that. Have them come back, reset, and then again. And then we come around and we do it on the other side. If we were gonna do more abdominal work, the first place to start is to work along the rib line here, but not here. So you have the sternum, which is has a couple extra pieces. This top piece is called the manubrium, and then this bottom piece is called the xiphoid process. That's where you aim when you're trying to punch someone, but not when you're trying to do massage, okay? So that you don't want to push on. It's right there where the solar plexus is, but you don't want to mess with that. So I don't do this. I work across, I find that I'm going to the rib line over here, and then just kind of working my way down that line. And that'll create, stuff can get kind of fibrotic and stuck up here, and that could potentially limit the diaphragm from effectively working. We're not doing a diaphragm release. To do a diaphragm release, I'd have to be like this. So that's not happening, okay? But I could affect the diaphragm's ability to function by creating more pliability here, because if this is tight, and then it's trying to expand the belly, and this isn't allowing for it, then that's problematic, right? So, just walking along that rib line, I come all the way over, and I do the whole same thing again. Knees up, but the knees would always be up. Would always be up. Rotate towards me, and rotate away. Rotate towards me, underneath, rotate away. And they stay up, yeah, they're not going to. And then across along that rib line. But at the very least, the twists, okay? The most common issue in pain care is low back pain. So even if not this, the twists, all right? It's a great way to end the session that isn't seemingly about their belly, but it's going to affect all those muscles in one big action, and it's going to potentially really help the low back. And it's also just kind of a nice thing to end a session with, especially if their goal is low back. What now has happened is I worked on their low back in prone, in each side, and then in supine. I worked on their back 4 times, I worked on your target area, I customized it to your goal and your needs, right? Same principle could be made about the neck. If I were to adapt and work on the neck a little bit in prone, but then both sides and here in supine, I've worked on it multiple times in multiple directions. But this one, undervalued, we don't have to necessarily completely undrape a person's belly button. But doing that twist action, really good.